You can really help people in urology, where when we do something and we get rid of the cancer, their survival changes dramatically by how we can intervene. So it's nice to give patients a good quality of life and be able to make a big difference. The top #1 indicator of bladder cancer is blood in the urine. Bladder cancer is cancer that develops in the lining of the bladder. So there's cells inside there, just like the inside of your mouth, and they're dividing all the time. And sometimes that signal gets changed in the division, and so it tells the cells to keep dividing, and that's what causes cancer. Things that may increase the risk of bladder cancer may be smoking, because that may cause those genetic changes to happen a little faster. Even though you think that's just in the lungs, it actually gets filtered out through the bloodstream and then exits through the bladder, so it might cause irritation. Some rare forms of bladder cancer can be caused by chronic infection. If somebody has a catheter for a really long time, it can cause irritation and cause those DNA changes. But a lot of patients have none of those risk factors. About 75 to 80% of patients with bladder cancer are male. Basically, we start by ruling out that it's an infection or a kidney stone. So you start with urinalysis just to make sure it's not an infection, and a CT scan. And then we do cystoscopy, which is putting a little scope inside the bladder and taking a look and seeing what's going on in there. If you're a patient diagnosed with bladder cancer, usually it is a multidisciplinary approach at this point.
They explained everything carefully to you, including all your options.
If your creatinine's fine and you're able to tolerate chemotherapy, we've found it improves survival. So a lot of times you will see the oncologist and see the surgeon, and you'll start with chemotherapy and then have surgery afterwards. In general, the chemo usually comes first and the surgery second. We do about 100 cystectomies every year. So 100 times a year we do bladder removal sort of surgery here, which is one of the high volume places. Gene studies, so that is one of the things we're doing lots of research on now, of trying to figure out the genetic profile for bladder cancer. The robot is a series of 2 instruments. There's a console and then there's the actual robot. The robot is basically a computerized system where scissors and forceps and that sort of thing can be inserted in tiny holes into a patient, and then I can operate those instruments by sitting at the console. The big advantage with the robot is smaller incisions, which lead to decreased pain and getting out of the hospital a little bit faster, also less blood loss. But we can actually build a new bladder that hooks to the urethra and hooks to the ureters that functions almost like a normal bladder. We actually use small intestine. So there's a portion of your intestine that absorbs a little bit of vitamins and minerals, but not enough. We just take part of it and we can open it up and make it so it doesn't squeeze anymore, so you don't have leakage, and fold it into a sphere that hooks to the ureters and to the urethra and works like a normal bladder. I guess I usually tell them that it's a big investment, that for 3 months it's a big surgery, it's a long surgery, it's a week in the hospital, it's a lot of recovery and you feel tired, but after 3 months your life is basically back to normal. So not to be really worried about it and deciding not to have surgery or not to do anything about it. So luckily only 20% or so of patients have invasive disease. So that means 75 to 80% of patients with bladder cancer don't even need their bladder removed.
Well, my experience here has been fantastic. Everybody's been very helpful and considerate. Well, I would say just keep up the great work, and she's just fantastic with patients and does a terrific job here.